to talk about some work which we've been doing. This research has been going on for almost 5 years now, and we've been improving on it from time to time. So I want to welcome all those in this particular course, and we will present, and I guess I don't know what the how you handle it normally, if they want to stop and ask questions in the middle, or if you want to wait till the end. But we would really welcome a lot of interaction and questions from the participants.
Great. We usually wait till the end to ask questions.
Thank you. So let me give the premise of this work. I've been working in the domain of telemedicine for over 15 years now. We started out in Ethiopia in the Mini League Hospital in Addis Ababa, as well as in Awassa. So we've been doing a lot of work in up to this day, when we now run a full training program, a diploma program in telemedicine and electronic health records. The last time I spoke to the Global Catalyst Summit, at the Global Catalyst Summit, invited by my good friend Will, I talked just about the telemedicine in general. Today, we want to focus on the issues of sustainability of telemedicine projects in terms of Sub-Saharan African countries, but in general in the developing world. One of the challenges that is being faced with the issue of telemedicine now is that it is largely still at the pilot level. A lot of foreign companies come in, they spend a lot of money, they implement this, it goes on the newspaper. This country has implemented a telemedicine initiative, but 2 years after the funding agency leaves, you don't hear anything about it. So the question is telemedicine a reality for Sub-Saharan Africa, especially if you don't have foreign funding? The initiatives that remain, for the most part, are largely funded by the Western world. So we want to discuss a framework that we have been developing after studying this. So we cannot argue one thing, that healthcare is one of the biggest challenges in Sub-Saharan Africa, considering the multiple health sector challenges. And I'm sure everyone in this audience, this slide means nothing to you, because you know the statistics. Sub-Saharan Africa is always been behind in terms of any WHO statistic that is out there. We still have a lot of children dying for basic things like malaria and so on. HIV is still not as bad as it was some 10 or more years ago. It's improving, but still you have more than 66% of about 22 million living in Sub-Saharan Africa. Still with HIV as of 2017, 13% lives in South and Southeast Asia. And so by the end of 2017 statistics, the percentage of people living with HIV in Botswana, Lesotho, and South Africa was still the highest in the world. This is as recent as a year and a half ago. Malaria, which can be easily treatable, is responsible for as many as half deaths of African children still under the age of 5. The problem with the statistics today is that usually governments would take statistics from urban regions where the death rates are much lower, and they say, oh, our countries have improved, but in reality, there are really still these issues that must be addressed in one way or another. It kills more than 1 million children, 2,800 per day, as of a year and a half ago, in Africa alone. You know, the diseases that plague the continent and lead to loss of millions of lives every year in Africa. You have dysentery, cholera, typhoid, yellow fever. I'm a victim. Being founder of the ICT University, I travel and visit all our campuses regularly, and just as recent as 2 weeks ago, while in Nigeria and Cameroon, I got typhoid. So it's real. I was diagnosed with it. It's a reality. One notable challenge in the Sub-Saharan African regions is an acute shortage of medical personnel and facilities. And the few that are really good and that are doing the work for very good reasons, they want to live in urban areas. I don't blame them at all. It's hard for governments to place doctors in small rural areas in Africa because they are not, those areas are not lucrative. And these doctors have to survive. So I don't blame anyone for wanting to be in an urban area where they can do their private practices as well as work for the government. So many developing countries have an acute shortage of doctors, particularly specialists. Sub-Saharan Africa, on average, has fewer than 10 doctors per 100,000 people, and 14 countries do not have, well, I mean, that's a mistake. They have less than 5 radiologists that we have counted. The purpose of this study is to develop a framework which will facilitate development, implementation, and sustainability of e-medicine in Sub-Saharan Africa. The telemedicine initiatives we talk about represent potential solutions to improve healthcare and accessibility, healthcare accessibility and quality. We had the case, and it's improved now in Ethiopia, but before you had people had to travel from villages and spend about a day and a half literally on the road to make it to Addis Ababa to simply get an X-ray done. Now it's improved. Some of these areas, these rural areas, are beginning to get the necessary machines needed for this. By the way, I'm not a medical doctor. I'm an IT guy, so I may make some say some wrong medical terms. Don't hold me on it. Modern day healthcare is offering more and more treatment alternatives on the internet, which we now call e-medicine. High penetration of mobile devices is becoming an advantage, where now in a lot of African countries, having a mobile phone is no longer a luxury item like it used to be. Everybody has it. Even people in villages have some kind of mobile devices. And with power banks now that have been manufactured that can be charged by solar power, people can recharge their phones whenever they want to. So in general, telemedicine has advantages where there is relatively inadequate or non-existent access to healthcare resources. So a number of things that we will discuss through this is, yes, telemedicine works well, but how do we sustain it over time such that the people that really need it, especially in Sub-Saharan Africa, can fully benefit from it, as opposed to just nice media stories about this particular hospital in this part of Africa now operates telemedicine. So sustainability, network theory, as well as knowledge management theories were used in this study to look at how to sustain telemedicine over time. So sustainability network concern properties that arise in systems of many objects linked together and displaying both static and dynamic complexity. But what do we mean by static complexities? You're talking about the networks, the hardware, the nodes, the links and flows, that critically loops and cycles, dynamics, modularity, trees and hierarchies. When you look at the dynamics of industrial systems that are particularly challenging, and it is here that the need for sustainability network theory is. So looking at the technology environment, the technological environment largely involves the current state of ICT infrastructure. And I want to present this in terms of a diagram so we can talk about it better. So if you look here, we have a number of things we look at in this sustainability theory. One, we look at the social environment Then we look at the technology transfer project environment as determinants of sustainable telemedicine outcomes. Let's discuss them one by one. With the social environment, you have to look at the current state of healthcare systems. In other words, you don't just say, okay, the Harvard Health Catalyst Group has some funding and wants to implement telemedicine in Cameroon, my home country, my beloved country. And so the Harvard Health Catalyst Group brings these telemedicine technologies and throws them in a very good hospital in Cameroon. Well, you have to ask yourself the question, what's the current state of healthcare systems? If a system is already so badly placed, throwing technology on it will not fix the problem, it will only accentuate the problem. If, for example, doctors are not showing up at work, you can put all the telemedicine technologies you want, it's not gonna help in any way. So what does this involve? We look at one, the institutional environment, the current state of e-medicine policy in the country. There must be strong policies by the governments of those countries on how to improve on telemedicine practices or to implement telemedicine practices in those countries, such that these things do not just run in the air. I talked about this particular aspect during my last talk at the Health Catalyst Summit. So in this case, for example, if the government has a policy that you can import computers freely into the country, and they do not have a specific policy that telemedicine equipment can be imported free into the country, well, while you can bring in computers, you may not be able to bring in some other gadgets that will help with installing and implementing a telemedicine system in a particular country. So that policy of improving ICTs in a country does not specifically or necessarily help with telemedicine implementation. Similarly, the aspect is the technological environment, the current state of e-medicine infrastructure in the country. So if, for example, the country does not have good internet connectivity, that becomes a challenge by itself. There must be some form of internet connectivity. There must be, like we mentioned earlier, the existence of mobile phones, yes, is there, but how much does it cost to buy data in those countries? So while African governments have done an excellent job bringing in mobile technologies that could help as part of the telemedicine infrastructure, if a medical doctor that earns less than $1,000 a year, if he or she has to spend about $200 in a month just to buy data to use for his or her telemedicine practices, it may not be practical. So cost of data, while it's really going down in many African countries, when you deal with transferring high imaging, for example, it consumes a lot of data. And so we have to look at specific technologies that could support the implementation of telemedicine by itself. We're talking about the infrastructure. And then we go to the technology transfer project environment. This is extremely important. The question here is, when, for example, an American company or a British company is bringing as a donation to an African country some telemedicine system, when they are there, do they use local management? Or is it just a group of expatriates that will come there, implement this thing, and then disappear and nothing happens after that? Sustainability has a lot to do with training the locals, not just as support staff, but as major staff, management staff, in running these telemedicine systems when they are implemented in those countries. One of the things we observed in several African countries, the few that actually implement telemedicine, even funded by the government, by the way, I don't want to call the names of any countries because participants may come from there, but I am talking about something personal that I have been involved with one country. The government would spend money, buy all these gadgets, but yet they bring in only expatriates to run it at those hospitals. The locals are not trained. In this particular case, the entire telemedicine staff was brought in from Chandigarh in India. Once the funding became a challenge, the group from India left because the government could not pay them, and that was the end of the story. If they had used locals, and I'm telling you, people don't need PhDs to run telemedicine technologies. A guy that has finished a first degree in computer science from any of our African university can lead the technological part of telemedicine implementation if trained. And the training, from what we have done in many countries, takes no more than 3 months to get a person to actually be able to operate these technologies and make them the managers. The other thing about the technology transfer project environment is the issue of complexity of the telemedicine projects. Now, the problem with many of our developing nations is this idea of, because it is implemented in America, because it is implemented in Europe, let's implement it in Africa, in our African country. Well, there are some levels of complexity. If you bring in things that are way too complex and your basic technological environment cannot support it, like I mentioned earlier, it is bound for failure. You get a wonderful 2019 Mercedes-Benz that has no gas to run it. It will just be a beautiful technology with no one to operate it or no resources to operate it. So the places where we have had successful telemedicine implementation are the areas where the projects, the particular implementations have been kept as low complex as possible to be able to run through the slow data networks that we have, as is the case in many African countries. We also have the issue of knowledge management practices, and Dr. Robert Isabalija will talk a little more on this at the end of my talk. The issue of knowledge management is extremely important in getting these, not only the doctors involved, but how about the nurses? The people that are not necessarily at the doctor level. The medical doctors are very busy people. How do you get other staff of the hospital involved in telemedicine? The mistake many make is that when you say there's telemedicine training, and I've been to several of such telemedicine training conference, you get a lot of doctors are those invited to attend. Well, these are very busy people. Why not look at nurses? Why not look at the people drawing blood, the technicians in the X-ray labs and so on, to train them in operating these technologies? We've talked already about the degree of donor involvement. Let's be very careful, and I've talked about this a lot. And the reason I talk about it is because, like I said, many of the current ongoing the current telemedicine projects in much of Sub-Saharan Africa are donor-based. For how much longer are we going to keep depending on donors? And you can't blame the donors because you get donor fatigue at a certain point. So how can we do this ourselves without necessarily depending for the long run on donors? I went to one of the most respected, one of the oldest universities in Africa. Again, I would not name the country or the institution, and I met with the dean of the School of Medicine, because the ICT University Foundation was funding a project for them in telemedicine, with the agreement that their government will continue to pay for the project after our funding period, which was a 3-year funding period. And we did indeed fund the project for 3 years. But what happened after that? I went to meet the dean and to find out how things will move ahead. And he said, Professor Mbarika, I'm sorry to let you know this, but we don't have the money to continue. If you can kindly help us develop some grants to continue to support this project, we'll be very grateful. That was the last day I saw this dean. I've never even went back to visit that university, because in reality, donors get tired. And we had an agreement, an MOU with the government, and everything was agreed upon. But when it came for the government to continue, they would not put in money for the project. So we've essentially, in summary, this study, we looked at this institutional environment, the technology environment, the technical environment, knowledge management practices, the social environment, and the donor involvement. Specifically, with the social environment, we talked about the institutional environment, the technological environment, as well as the degree of donor involvement as determinant of sustainable e-medicine outcomes. So I will, all of these slides following, I will give them to you. They're just a repetition of what I've been talking from the model we are presenting there. I think it will be richer if we have some kind of interactions. I don't know if Dr. Isabalija, are you connected? We may have connection problems with him. The central contribution of the work we are doing is a call for information technology or information systems researchers and telemedicine practitioners to extend the sustainability of information systems to the developing world. Okay, please, can you go ahead and talk about any additional things I have not covered, please?
Thank you, Prof. I must thank you for a wonderful job you have done on this work, and I must say you are the grandfather of telemedicine. I'm the grandson. When we did this work a few years ago, we didn't know that we would reach here, and we must thank you for allowing us to present it. And thank you, Prof, for taking on telemedicine to this level. To the class, I must say that when we took on this research, we really thought that sustainability and knowledge management was something that was lacking after work that had been done previously by Professor Mbarika as his PhD work. So we picked on it and still worked with Professor Mbarika to refine it, to see what was lacking. And knowledge management was one of the key things to help in sustainability of these projects. A lot of these projects are started on as we are talking about. Telemedicine in some of the African countries was also started on as projects, standalone projects. But then these were systems being embedded in the health systems of Africa. We thought if they were embedded, they'll help, looking at the background that Professor Mbarika has given. And one of the big implications that we found when we're doing this study was that we are against the notion of action research that end up in changes that last only as long as the attention of action researchers remain, or similarly, or end up with a prototype that is never originally used systems. So we postulated a model for sustainability of e-medicine, which was much needed in Sub-Saharan Africa, because to us this was key. I'm also from Uganda, so part of this data we could see, as Professor Victor has maintained, that yes, it is true, typhoid is real. He says he was diagnosed in it. But most of this is a reality that we did. But we also had an agenda on the brain gain hypothesis. A lot of us talk about the brain drain. So this study had a basis of the brain gain. How do we reverse the notion of the brain drain, which is it talks about? And that would only work on using knowledge management. Knowledge management would mean that after we have got this, after we have seen what telemedicine can do, and we have people who are in the developed countries, like how Professor Victor is working right now, how do we have this knowledge transferred back to these countries without necessarily having people go back, but embedding it there? So the human capital stock would increase by us having these systems. So this study sought to establish management platforms to ensure knowledge sharing and management, which would go ahead in solving problems of resource poor settings in Sub-Saharan Africa. We're also trying to remind the e-medicine research community that the problem of sustainability, much as it had been overlooked, this would help to constructively describing an alternative approach sustaining the sparse telemedicine initiatives in Sub-Saharan Africa by establishing a framework that addresses the criterion on sustainability. And that's what we are talking about. So most of the studies and most of the works done right now, as you can see in some of the projects and program implementation, sustainability is being emphasized. How are we going to sustain this? How are we going to sustain this? We found the construct of knowledge management as being the biggest thing in sustaining this. Also, this study sought to abandon singular one-site or one-site e-medicine projects in favor of a network of sites and establishment of databases across country sites by governments in local and referral hospitals to generate local self-sufficient learning processes together with working mechanisms for distribution of appropriately formatted experience of knowledge acquired across sites. This one, when you go into our detailed study, you'll discover what that. So, I'm sorry. Hello?
Yes, go ahead. We're hearing you.
Yes, we are hearing you. Please, I sent you a...
Yeah, I'm having some connection problem.
So that you can click on it and present. If you are presenting from your computer.
Oh, yes?
Yeah.
Hello?
Yes, we can hear you. We can hear you clearly.
Okay, but
Yeah.
I'm not...
I thought you were presenting from your computer, so I sent you the link to make you present.
Oh, no, I'm presenting from my phone. I'm very far.
Okay, no problem. All right.
I'm in...
Yeah.
Yeah, so for practice, our findings also suggested a roadmap for deliberate, to be deliberate about sustainability efforts by virtue of development and implementation of a sustainability plan in e-medicine. In light of research that discusses how early sustainability is an important step toward actually sustaining programs. So it's important that this concept is put in place early when we are doing this. So in brief, those are those, especially for the policy frameworks that we developed. That is a simple synopsis on some of the policy implementations that we did. Prof, are you there?
Yeah. Yes, please. Thank you so much, Doc. One last thing before we allow questions. Assistant Professor Folusho will conclude about our training, and then we will take questions.
All right, this is Assistant Professor Folusho from the ICT University System, also with the Southern University and A&M College here in Baton Rouge, Louisiana. Now, as we can see, some of the implications of this work is the sustainability of telemedicine in Sub-Saharan Africa, because we know sustainability has always been an issue, and for the most time will continue to be an issue. So one of the initiatives we are carrying out is to train health institutes, medical doctors, medical practitioners in Sub-Saharan Africa on the use of HIT health information technology systems. We also deploy some of these systems so that we train them on how to use it. We train our medical school students on how to use health information technology systems such as the electronic medical records and telemedicine equipment, such that when they acquire this equipment, they are able to use it and also, train incoming students and resident doctors on how to use HIT. Because believe me, in Africa and in Sub-Saharan Africa, most of these medical doctors and medical students don't just know that they have failed to really adapt, information technology in healthcare, and that is what we are trying to do. This is a new initiative. We train them such that when they acquire these systems, they are able to teach their students, they are able to infuse HIT into their curriculum. And we've had a lot of institutions, some institutions who have adopted this, and this is what we are trying to do, so that telemedicine is sustained, because we are taking this theory into practice now, because we have been preaching telemedicine, we have been doing a lot of research in this area, HIT and telemedicine, but we want to really put it into practice by training Sub-Saharan African medical doctors and students and resident practitioners. And I think with this, we have been successful, so far, and this is what we are continuing to do. We'll continue to do in the next coming years. And we envisage by 2021 a number of Sub-Saharan, especially in less developed and developing nations in Sub-Saharan Africa, where healthcare is still a very big challenge. So this is what we have been doing. I think Professor Mbarika will continue from.
All right, we want to open up for questions, I guess.
Okay. Professor Mbarika, I sent you the link again. Can you click on it so that we see your screen? Yeah.
Can you see our screen now?
Not yet. I sent you the link. If you can click on it. Just give me a minute. Let me make it so again.
Oh, okay.
Okay, yeah, we can see the screen now. We can see the screen. All right. Okay.
Can you see it?
Yes, yes.
Okay. All right.
All right. So, question time, please. Okay. Okay. So, okay. Just a few questions I have. So, first and foremost, for health information system entirely, Professor Mbarika, like you said, is there any special training besides the common information and communication technology, let's say the degrees we have in universities, the training that people basically receive? Is there any difference for people who are particularly going into healthcare? Do they have to get any training to be certified for health information technology itself as different from the general information and communication technology?
Absolutely. There is what is called the DIP-HIT, Diploma in Health Information Technology, that we have implemented in a number of countries in Africa. In fact, in Nigeria, I think that's your home country.
Yeah.
We did it at University of Jos. We are about to start it at Kaduna State University, and we've done it all over Sub-Saharan Africa. But no, it goes beyond just regular ICT training, because you have to really train them on developing electronic medical record system, being able to configure it from scratch, as well as using it. So not only being users of the system, but being able to be developers of the systems. And then when we're implementing it, we always involve medical school students to see how these implementations take place, because the trend has been that it's the Western world that will come and do this. Well, locals have to be trained how to do it themselves, and that's exactly what we do. And at the end, it's a 2-semester program. The first semester is a certificate in electronic health records, and the second semester is certificate in telemedicine. The 2 certificates combined per the accreditation body that gave the accreditation for that constitutes the Diploma in Health Information Technology.
Thank you. So what's the accreditation body for your for the program?
The ICT University is for Africa is headquartered in Cameroon and is accredited by the Ministry of Higher Education. That's the sole body that grants accreditation to any institution that wants to operate in the country. And we have bases in Uganda, Zimbabwe, and right now the Nigerian government is just giving us infrastructure to start a unit in Kaduna.
Great. So here's a question from Adeniji. It says, he said, it seems that the sustainability is the real issue with telemedicine in low and middle income countries. What should be the way forward in these countries then?
Oh, this is a great question. And I will bring back what we have said. The number one thing is training the locals. It has to start from the medical schools and the nursing schools. They need to have courses in health information technology. They need to implement, they don't have to have a whole diploma in it, but they need to have training at that level in health information technology. There's no way around it. The truth is the current people that are already stable and working, the people in the healthcare sector in Africa, especially medical doctors, they are fine. They don't really need to know telemedicine to survive financially. But if this can now start with current medical school students, current nursing school students to receive training at that level, that is where we have seen countries that have used that approach beginning to sustain telemedicine.
Prof, I wanted to say something.
Please.
One of the things that our study postulates is knowledge management. Knowledge management was seen as one of the key intervention. And of course, we need to look at it in knowledge management in terms of the way how leadership looks at it and how the lower people. Now, you can start at the lowest level, which are the village health teams in some of these countries that they have started. One of it is how, when you establish a telemedicine project, how do you make sure that there is a repetitive action and that repetitive action is properly documented? That's why we talk of databases, how we talk of having this continuous engagement with the people that are doing the same procedures. For example, we talk about how do we tap into doctors from US, how do we tap into doctors from Europe? But then when those doctors perform particular actions, how are those actions kept such that when there is a repetitive problem at any level, that it works? And looking at that, you must look at the lowest entities, how Prof has said, how do we train at the lowest? And at the lowest, we are even talking about the village health teams, from village health teams to small practitioners, to nurses, to medical assistants, to doctors. Now, when we talk about doctors, what e-medicine does is that if a cardiologist can performs a procedure with somebody in Uganda from United States in New York, how does this person keep the same knowledge in Uganda to perform the same procedure next time without referring to the doctor in New York? That must be documented. So it needs to have systems that are continuous. So sustainability looks at continuity. It looks at when somebody has left, can we find the same information that was used? So those interventions must be documented, they must be kept, and you must continue working. That is what sustainability is all about. It's not a one-day issue that you establish. It's not a one-day issue that you try. It is continuous.
Okay.
All right?
Yeah. Thank you very much. So I have this other question from Maruf Adewale. He says, there is electric power challenges. Power challenges across Africa. Do you have any strategy in place to forestall electricity disruption in telemedicine infrastructures?
Great question. It's one of the things we had in our model is the current state of IT, just basic IT infrastructure. and power is absolutely one of it. While many African countries are really improving with issues of electricity, issues of power, there are still countries like Nigeria and Ghana that are still really having major challenges with power, and many times people have tried to go with like solar energy and so on, which has helped some areas. But one of the things which we've seen developing, which is really nice, is the idea of mini dams, which you can actually do to power a community of about 10,000 people. In fact, in terms of power, I think I will leave it to Professor Isabalija, because he actually was the Vice Minister of Energy in Uganda. So I think, Prof, you can address this issue of power much better than me. I don't know.
No, of course, one of the things that we have been doing on that is solarizing most of the people, most of the technologies in Africa. Solar has become one of the things that is changing the way how we are doing medicine and also doing business in other things. If you move now in Africa, most of the places, at least compared to the last 5 years, at least every remote village has some solar connection. So solar connection is going to help. And in doing this study, we say that telemedicine must work on the minimal input of power. At least when you have a small solar backup, if it can help on powering a phone, that should help you much. That should help you in logging in. You can see I'm here in Turkey myself. I have logged in through a telephone. What would stop a person in the village to log in through a telephone? At least compared to the time when we did the study, the telephone, the internet penetration is much higher compared to that time. So I think there is more light now, more light in internet penetration, more light in power connections, at least on polarization of some of the communities.
Oh, thank you very much.
Mm-hmm.
Yeah. Okay. Like in many, so this is from Akintayo. Like in my hospital, telemedicine is in use in radiology department. Our greatest challenge is power. Also, many of our health professionals are not computer compliant. How do we tackle this locally? How do we tackle this locally in the facility where I work?
Yeah, I'll address the issue of ICT compliance. That's exactly what Assistant Professor Folusha was talking about. And please, Robert, you will tackle again the issue of power in that. The reality is people have to be trained. There is no way around this. And what we have tried to do is design the training to be very as affordable as possible, and pushing the governments to foot the bill to be able to have their healthcare professionals trained. One of the challenges we have with training is when you call for a workshop on theory, the medical doctors will come. That is easy. They will come sit for 2 hours and listen to you. But when you call for actual hands-on training, the medical doctors in much of the African countries we work with are very busy. They have so many patients to handle, and they don't have time to come sit there. And so the solution is to, like Dr. Kintaw is saying, to be able to bring in some of the lower level staff to come for this hands-on training and be able to run these things for the medical doctors. There is no way around it but training. And we are offering those solutions, and anyone interested can contact us directly, and we can organize to do trainings in their healthcare units. We'll be more than happy to do that. We are doing that in many countries in the developing world. But even if it's not us, the government need to bring in telemedicine experts not to implement themselves, but to train people how to do it.
Wow, thank you very much, Mbarika.
Yeah, again, Prof, on the issue of power, these are deliberate efforts that must be made. As I've told you, solarizing is one of them. because there are equipments nowadays which work, which don't necessarily require a lot of that power that we are talking about. But then this is going to be a deliberate effort for it to work. I can share my experience on how mobile money has changed. For example, the way how economies are managed. If you Google right now, you're going to discover how most of the East African countries are operating the economy based on mobile money. Now, this must be a deliberate effort. Are we ready to change how medicine is done? Are we ready to deliver services faster? So this is going to be a deliberate effort. Again, I should say that most of the African countries, some right now, are making a deliberate effort to increase their power. If you look at East African countries, I'm talking about that because I have more experience there. Most of them are on a deliberate effort to increase their power load. The main thing now is how do hospitals adapt? So power is not the biggest problem, especially where hospitals are. The big problem is adapting to these telemedicine practices and making them sustainable. If you ask me, that's the huge issue right now, is people adapting. But adapting with the current pace of technology penetration, it's going to be.
Wow. Thank you very much.
All right.
So Adewole ask again, how can members of this class benefit from telemedicine training and practice, noting that we are no longer in medical school? We are no longer in medical or nursing schools.
For our training, I think you distribute these slides, right?
Yes, sure.
We have our email address on there. You can email us, and we will be glad to give them different options on how they can be involved with the training and things like that. They should just email us. That will be the easiest thing. The email address on her first page, unfortunately, the word president was spelled wrongly, so they just have to correct that. president@ictuniversity.org. I think that's what I would suggest.
Okay. So, so thank you very much. So, what about? So this is a question from Obina as well. So thank you, Prof. Since most of us are no longer, so what is the estimated time and period for training?
It's 2 semesters. For the health IT training, the diploma program is 2 semesters of training. The first semester is 3 months on electronic health records, and the second semester is on telemedicine, also for 3 months.
Great. Thank you. And what are the requirements to getting into this program? Do you need to have passed your SSC, or do you need a first degree, or things like that?
Typically, we train anyone in the healthcare sector, first of all.
Yes.
But we also open up to people with degrees in information technology, information systems, and then when within the healthcare sector, they get to learn more about the healthcare side. Because really much of this, for example, electronic health records, those are really databases. Let's just be direct, okay? They're databases which we have modified them to involve healthcare terminologies. So even IT people with from HND and above can be involved in it.
Oh, thank you. Stanley says, how do we deal with the pessimism among healthcare professionals? The thinking that this will never work. A lot of them are a little pessimistic because of the staff we have on ground, the low manpower and the lack of the necessary infrastructures. So the mindsets or the pessimism, what do you say about that?
First of all, I would like to tell him he is 100% correct. Even in our the case studies we've done on ground, there is pessimism. Reason number one, when a lot of these donors came in, there was a lot of promise. I remember some 15 years ago, when we started this in Ethiopia, the president of Ethiopia, the prime minister of Ethiopia was involved. Everybody came. The AU gave us their hall. It was huge. Everybody was excited, and the project started. The issue came to when it had to move from the donors to the government. Then they started running away. So yes, the healthcare professionals in these countries became disappointed because they had attended all this training and now they can't do anything. So I absolutely do not blame my dear brother for thinking that way. There is indeed a lot of pessimism. How do you deal with it? I think it comes again with individuals. It takes one person to make a change, to start making a change. If there is one person dedicated to seeing telemedicine work in a healthcare institution, usually, especially people that maybe have some managerial role in those institutions, we've discovered that the role of leadership does help other people to follow. But if the leadership is absolutely not interested, like the chief medical director, or whoever is the administrator of the hospital, if they have zero interest, I tell you, I'm not sure I have a solution for that. I would just say the individual healthcare professional should think about their own career and that this is the way the world is going. Like I said, I had typhoid and it was diagnosed in Nigeria. I went to the doctor, and I rarely go to doctors. And it was, besides for my physicals, and they were still using, in a very good private hospital, by the way, they were still using hospital books. And it was one of their top hospitals. Okay, so they were not even using a database to bring in patients. And so the individual healthcare professional should take it upon themselves and say, you know, I want to learn this thing.
Great. Thank you. Okay. Yeah, please go on. Yes, we can hear you.
Mine is just a suggestion, particularly to some of us in the Sub-Saharan Africa. I personally believe that at this capacity, if I can see the comment, most of us are trying to empower themselves directly or indirectly. But I think we need to think a little bit beyond that. Particularly, we pilot a project of a palliative care. We did a simple survey of knowledge of oncology among medical students, and we realized that there is quite deficiencies of oncology knowledge in South African medical curriculum, and that similarly apply across the globe. What we did was that stimulating the various medical institutions, bringing that into their curriculum, and that enabled it. In fact, I believe that the new generation doctor will have a reasonable knowledge of oncology. Similarly, in terms of the telemedicine, instead of us at this level trying to be empowering ourselves, I believe those who have the capacity and the political support in order to stimulate various medical schools to incorporate either some model to the telemedicine in such a way that the young generation doctors will come out with a fresh idea of having the telemedicine as a part of backbone. It will really make a reasonable changes than individuals we empower ourselves. And as he earlier mentioned, most of us are busy. We may have the knowledge, but we cannot apply it at the end of the journey. Just that is my general observation. Thank you.
Thank you very much, Dr. I'm very sorry, Zugol. Your name is very long and hard to pronounce, sir. Thank you very much. So I just want to say beforehand that hopefully in future, in the next cycle, we will be partnering with the ICT University, Global Health Catalyst, to offer some developing partnership with ICT Professor Mbarika's University to offer training for the next cycle, given the network they already have on ground in Africa. we hope we may be able to utilize that to extend training activities in ICT technology.
That would be wonderful. I really look forward to that.
Yes, great. Thank you, sir. And so someone asked a question also. He said, what are your three main top challenges right now in education, especially for healthcare professionals?
Okay, I hope this will not be held against me, but the number one challenge we are facing, the number one, is just the governments we deal with just telling the truth, you know. Yeah. I'm not sure I would call it lying, but it's really been hard in the last 15 years for any MOU we signed with any African government, with no exception, for them to really keep to what they signed to. It's really hard. The second challenge now, forget about the government, go to the institutional level, the hospitals. You have a chief medical director, you've agreed on something, a 5-year project, and administration changes, they fire him, they bring whoever is the political boy or girl of the next person, and they come on, and they want to start their own thing. So whatever you had agreed on, there is no sustainability, because they will say what their predecessor started, if they continue, is their predecessor that gets credit. And we don't get credit. It's a huge challenge we are facing in many African countries, not just in hospitals, but also at the level of universities. Once a vice chancellor changes, whatever project you have started with them, you could, for the most part, almost just walk away, because not all, but I say for the most part, see that the new person that comes on wants their own identity, because they want their own credit. You will hear words like, I want my own legacy.
Yeah.
And there is no legacy of building on what the predecessors started. So the issue with this is, these are the two challenges I say. It's not necessarily the technology in this case, it's just the human challenges, because these things can be done. When you start training students in medical school on health information technology, if you do one semester and in the middle administration changes and they say, oh, our priorities have changed, so you know they cannot continue to the second level, well, you have ended it halfway. And your predecessor already spent some money, so that money is wasted. You know, so we have those challenges. Then, like we mentioned, in terms of the technology itself, having the locals being involved in management. Now, the issue with telemedicine right now is the payment for doctors that use telemedicine in some of the countries we work with, the payment comes from the government that compensates them. However, there are many of the African governments that will not, if you work for a government hospital, will not give you anything extra because you are on telemedicine. So it's not a motivation for the doctors to use it. So why would I be involved with telemedicine if at the end of the month I get only my usual salary as a medical doctor and I can take the rest of my time to do my private practice? So there is no motivation, no financial motivation for the doctors that are at least giving an effort to be involved. So what usually happens, unfortunately, is those doctors will be involved in the pilot. But beyond the pilot, they drop out because they need their time. And by the way, I don't blame them. They have families to feed. They have to take care of their families. They will not, telemedicine is an additional burden on them.
Thank you very much.
I have something to say. Can you hear me?
Yes, we can hear you.
I think just last year, the Minister of Health actually told my facility to visit a center in Kefi. They are actually currently on telemedicine. Yeah, they are done with using files and prescription notes, even for their patients and a lot of things. And we were a lot of teams that went there, and we actually saw it. And we also still have the problem of implementing it down in my facility. Our systems are actually configured to actually run on telemedicine. And I will tell you that one of our greatest challenges are the physicians. They are not compliant at all in my facility. And I think the medical director is actually going all out to see that they must comply and these things must work. So my hospital wants to actually go out of using paper. Even patient record, we want to start using Chromebooks. So actually, we want to scan all the patient's folder and then get them on our systems. And you don't need to go with papers any longer. So we are still working on it. And I hope it works in my facility. Thank you.
Yeah, thank you very much. Okay, we are way on time. I think this is 12 o'clock Eastern time, sorry. So this is 5 p.m. GMT. All right, so I will just give contribution for one more person, maybe to say something before we round off. One of the participants. Okay.
I want to say a very big thank you, and we are actually expecting them in Nigeria.
Yeah.
Oh, okay. We'll be delighted to be there. Just send us an email.
Okay.
We are in Nigeria just about every 3 months, actually.
Great. All right. Thank you very much, everyone, for attending today's class. And the video will be available. I'm sure you got the link last week to our YouTube channel. Hopefully, we'll have this uploaded too as well. And I'll try to send the notes to everyone. Thanks for participating. Thanks very much, Professor Mbarika and Dr. Isabalija, for taking today's class. My appreciation. So with this, we come to a close. Thank you very much.
Thank you.